Impetigo. Definition. Impetigo represents a superficial skin infection caused by gram-positive bacteria, usually S. aureus, and less commonly Streptococcus pyogenes. The early lesions are pustules, which quickly break to form crusts. Crusts are the most commonly encountered clinical lesions. Some strains of S. aureus can also cause blisters, bullous impetigo. Note, most impetigo is caused by S. aureus. Impetigo, pustules and crusted plaque with surrounding erythema. Incidence. Impetigo occurs most often in children and is the most common bacterial infection in children, with more than 3 million cases occurring annually in the United States. Impetigo ranks as the third most common skin disorder in children after dermatitis, eczema and viral warts, and is the most common skin infection presented in general practice by children aged 1 to 4 years. Nasal carriage of S. aureus leads to a higher risk of occurrence in children. History. The eruption often starts as a single lesion, but patients and parents often do not seek medical help until multiple new lesions develop. Other family members are sometimes affected. Staphylococcal bacterial infection also occurs secondarily, impetigenization, in association with certain skin diseases, especially atopic dermatitis. Physical examination. The most commonly encountered clinical finding is a honey-colored crust. Intact pustules are usually not found. When the crust is removed, a superficial glistening base is revealed. Impetigo does not extend deeply, so ulcerations are not present. Lesions can be found anywhere but are most often located on the face around the nose and mouth. Brown or honey-colored crusts are also the hallmark of secondary bacterial infections. Differential diagnosis. Different from the staphylococcal impetigo described above, ecthyma is caused by group A streptococci, but much confusion exists regarding these two types of bacterial skin infection. In both types, the presenting lesion is usually a crust, but the more important clinical difference is the depth of the infection. With staphylococcal impetigo, the process is superficial, just below the stratum corneum. So when the crust is removed, only a shallow, glistening erosion is seen. In streptococcal pyoderma, the infection is usually deeper, extending through the epidermis, so when the crust is removed, a deeper defect, an ulcer, is noted. In addition, with staphylococcal impetigo, there is usually little or no surrounding erythema, whereas with streptococcal infection, erythema is moderate to marked. Finally, staphylococcal impetigo is most common on the face, whereas ecthyma is usually found on the lower extremities, occurring after a scratch or insect bite. Eczematis, Greek, to boil, dermatitis, including nummular and atopic dermatitis, can be confused with impetigo. The oozing from the inflamed skin leads to crust, and history and physical examination findings help distinguish impetigo from eczematous dermatitis. Impetigo in the axilla, annular plaques with central erosion. Petrolatum ointment hides the scale. Ecthyma on the lower leg, streptococcal skin infection extends more deeply, often forming an ulcer, ecthyma. Eczematous dermatitis, crusted plaque in elbow crease in the setting of atopic dermatitis. When the vesicles in herpes simplex age, they become cloudy and eventually form crusts. At this stage, herpes is often misdiagnosed as impetigo. Features favoring herpes include the recognition, by patient or physician, of clear vesicles present at the start, a history of recurrence in the same location, and the presence of erosions with scalloped borders. Inflammatory fungal infections can cause pustules and are in the differential diagnosis for sterile, pustular processes. KOH examination and fungal cultures are indicated in patients with negative gram stains and bacterial cultures or in patients with a poor response to antibiotic therapy. Differential diagnosis of impetigo. Ecthyma. Eczematous dermatitis. Herpes simplex infection. Fungal infection, candidiasis. Herpes simplex. Note erosions with scalloped borders. Honey-colored crusts represent secondary impetigenization. Laboratory. A gram stain reveals gram-positive cocci. Bacterial culture typically grows S. aureus. In obtaining material for gram staining and culture, the clinician should first remove the crust so that the specimen can be obtained from the weeping, glistening erosion. Biopsy is rarely performed but would show a subcorneal pustule. Impetigo. Epidermis, subcorneal pustules. Dermis, mild inflammatory reaction in the upper dermis. Therapy. Both topical and systemic antibiotics have been advocated for treating impetigo. Uncomplicated impetigo resolves on its own after approximately 2 weeks. Topical preparations such as over-the-counter bacitracin and triple antibiotic, neomycin, bacitracin, and polymyxin, ointments and prescription mupirocin, Bactroban, and retapamulin, Altobax, ointments are used for localized impetigo. General hygiene measures are also recommended to prevent its spread and recurrence. For more extensive lesions, systemic antibiotic therapy is preferred. Most S. aureus strains, including those encountered in outpatients, produce penicillinase, so penicillin is not an appropriate treatment. The preferred antibiotics are oral cephalexin or penicillinase-resistant penicillins such as dicloxacillin used over a 7 to 10 day course. The increasing resistance of S. aureus to erythromycin may limit the usefulness of this agent in impetigo. MRSA has also been encountered and requires a tailored antibiotic regimen based on sensitivities, with doxycycline and trimethoprim sulfamethoxazole double-strength commonly prescribed. Therapy for impetigo. Initial. General hygiene. Antibacterial soaps, chlorhexidine gluconate. Changing of towel, washcloth, shaver, etc., daily. Bleach bathers, 1/4, 1/2 cup of bleach in 1/2 tub of water. Antibiotics. Triple antibiotic, mupirocin, or retapamulin ointment, applied TID. Alternative. Systemic antibiotics. For more wider spread infection. Dicloxacillin. Cephalexin. Systemic antibiotics, for MRSA, based on its bacterial-resistant patterns. Doxycycline 100 mg BID, for older than 8 years of age. Trimethoprim, sulfamethoxazole double-strength BID or 4 to 6 mg per kg BID. Course and complications. With appropriate antibiotic therapy, prompt healing is to be expected, with marked improvement within several days in most patients. Bacteriologic cure is achieved in 7 to 10 days in nearly all cases. If a rapid response to therapy does not occur, the physician should consider the possibility that the infection is caused by an antibiotic-resistant strain. In such instances, the result of the initial culture, if obtained, serves as a guide in selecting an alternative antibiotic. The bacteria can colonize the skin without causing actual infection. This is particularly true in patients with chronic dermatoses such as atopic dermatitis. More than 10% of patients with atopic dermatitis have S. aureus colonizing their eczematous skin. Impetigenization, characterized by honey-colored crusts, occurs more often in these patients than in those with psoriasis. Naturally occurring antimicrobial peptides in the skin are deficient in patients with atopic dermatitis, thereby leading to increased susceptibility to bacterial infections. Complications are rare. Acute glomerulonephritis may occur as a sequela to skin infection from streptococcal but not from staphylococcal infections. This emphasizes the importance of discriminating between these two types of skin infections. Note, honey-colored crusts indicate that the skin is secondarily infected, which can be difficult to differentiate from the oozing of inflamed skin in atopic dermatitis and nummular dermatitis. Pathogenesis. S. aureus is ubiquitous in the environment. With staphylococcal infection, trauma to the skin is often subclinical, and most patients cannot recall obvious trauma to their skin. Once bacteria have gained entry, they establish infection in the uppermost layer of the viable epidermis, just below the stratum corneum. Inflammatory cells, primarily neutrophils, respond and are responsible for the pus that is clinically evident and eventuates into the characteristic crusts. Infection with group A streptococci is more difficult to establish. These organisms do not colonize normal skin but must be inoculated through a damaged surface, such as a scratch or insect bite. Once established, the organism produces proteolytic enzymes, which are in part responsible for the surrounding inflammation.
Clinical case. A 7-year-old boy is brought to the dermatology clinic with multiple itchy skin lesions around his nose and mouth that started 5 days ago. His mother reports that the lesions began as small vesicles that quickly ruptured, leaving superficial erosions covered by thick honey-colored crusts. The child is otherwise healthy and afebrile. Physical examination reveals several erythematous erosions with characteristic golden yellow crusts on the perioral area. No mucosal involvement is present. What is the most likely diagnosis? A. Impetigo. B. Ecthyma. C. Eczematous dermatitis. D. Herpes simplex infection. E. Candidiasis. Correct answer, A. Impetigo. Explanation. Impetigo is a superficial bacterial skin infection, usually caused by Staphylococcus aureus and/or Streptococcus pyogenes. The hallmark finding is honey-colored crusts developing after rupture of vesicles or pustules, especially on the face of children. Ecthyma is a deeper form of impetigo characterized by ulceration and thick adherent crusts, typically on the lower extremities. Eczematous dermatitis presents with pruritic erythematous patches and plaques with scaling rather than honey-colored crusts. Herpes simplex infection usually presents with grouped painful vesicles on an erythematous base and may recur. Candidiasis commonly affects intertriginous areas and presents with erythematous plaques and satellite pustules.